Hi everyone, Dr. Simon Fryler from the Clinical Neurophysiology channel here. This video is actually part of a symposium for the Neurology 2020 course at the Institute of Neurology. That's upcoming. A couple of years ago I gave a similar lecture and had an hour to do that. So on this occasion I've only got half an hour, so I really need to be very focused during the actual course itself, and we'll be talking about case-based data interpretation of the type of things that you as a neurologist may be coming across on day-to-day practice, and so that's going to be recorded separately. This is actually just a preparatory talk in a way to give you a flavour of what neurophysiology is about. It's not just about the numbers, just to show you what the tests look like on the screen. It's a little bit more interesting rather than just the dry numbers themselves. So I hope you find that interesting and illuminating as to what we actually get up to doing. So without much further ado, let's dive straight in. Let's start with an overview of what we're going to be talking about. Let's talk about the basics. Let's show you a little bit of the equipment, some of the techniques, demyelination patterns, localization, and then a little bit on EMG. Now, if you have a look at my YouTube channel, the rest of it, there's lots of information about any one of these individual points, but this is just an overview. We'll start with this wonderful specimen over here from the Royal College of Physicians. If you haven't already been to see it, then I would recommend that you do. The Under the Skin exhibition will be closing pretty shortly, so make use of the opportunity to see it. This is a specimen, an anatomical table from Italy, and amazingly they've managed to take the nervous system and squish it into 2 dimensions, and it's really interesting, particularly if you want to try and work out which nerve is which. But in terms of what I'm going to be illustrating with this right now is we basically in neurophysiology have 3 groups of tests. The first group of tests are the nerve conduction tests and EMG, and that will basically assess the peripheral nervous system all the way to the dorsal root ganglion to assess the sensory side of things, or to the anterior horn cell in terms of the motor fibre pathways. We have the EEG, which will assess the cortical signals directly, and then we have the evoked potentials, which essentially assess the central pathways in between. The peripheral nervous system is of course made up of different types of nerve fibres. You can categorise them by their size, so some of them are large, some of them are small, some of them are in between, and the important point to remember is actually there's not very much difference between the large and the small fibres. We're literally talking about micrometers. So the very small nerve fibres are just a couple of micrometers in diameter, and the larger ones are in the range of about 20. And we can also describe the nerve fibres and classify them by the degrees of myelination too. Symptoms for patients may be positive or negative symptoms, and these are really important pointers as to working out whether one may be having a large fibre peripheral neuropathy group of symptoms or a small fibre neuropathy group of symptoms. So the small fibre ones tend to provide more positive symptoms, and the large fibre ones tend to give more negative symptoms, so more loss of function. Importantly, in terms of why I'm talking about this right now, is the nerve conduction studies basically measure large fibre function, and it's important to bear this in mind. Of course, large fibre dysfunctions will often include a small fibre dysfunction as well. So if, for example, you have a patient who has got a predominantly small fibre dysfunction and one's looking for evidence of this, and that is quite difficult to do directly, if there is already a large fibre dysfunction, then that can certainly cover that too. And a small fibre dysfunction, either in isolation or perhaps heralding a more diffuse fibre neuropathy, you might start thinking about things like diabetes. That small fibre dysfunction can precede a large fibre dysfunction by a couple of years, or those who have perhaps alcohol excess. Again, small fibre functions will start first. Now, there are very specific ways in trying to test these small fibre dysfunctions. Some of these you can actually do with your standard nerve conducting equipment. For example, the sympathetic sweat responses or the cutaneous silent periods are things you can actually already do with your nerve conduction tests. And I've got separate videos on all of those type of things. Thermal thresholds are done with very specialized equipment. Then there's the quantitative, sensory and autonomic tests, and of course skin biopsy, which can all be used to have a look at the small fiber dysfunctions. But basically what I'm going to be talking about here and describing over here in this lecture are going to be about the large fibers, and those are assessed with the nerve conduction tests. All machines are a variation of the following: a method for stimulating the nerve, a method for recording from the nerve, some form of interface with which to do things, and then a computer which has to communicate with all of that. So if we start with the sensory studies, there are a number of different ways in which we can do things. I'm going to start by showing you, here's a hand over here, and these are some ring electrodes, and they are over the second finger, which is of course median. And these electrodes over here, over the wrist, are also overlying the median nerve. Now, you can actually stimulate and record either direction, and this is, in this particular setup, these ring electrodes are being used to stimulate. These pads over here are being used to record. The pad in the middle is actually the ground and making the patient electrically neutral to the machine. The reason that we need to have two electrodes is to spread the current from one to the other, to generate those currents going forward. Of course, when we're doing a nerve conduction test, we're actually not interested in trying to stimulate these skin receptors to then send the signal along the nerve. We're actually depolarizing the nerve directly. There are ways of looking at the skin receptors, but in terms of what we're doing, the charges that we're giving, we are directly stimulating the nerve underneath and depolarizing it, and then those signals are then being picked up by these two pads. The reason we have two pads, I'm not going to go into details over here, it's called differential amplification. It's to remove biological noise from the signal and to have a good signal to noise ratio. So that's why we have two pads. Now, over here, I'm actually using a stim troller, or you can use bar electrodes. So it's another way of delivering that charge, and because we are sending the current in this direction up the arm in the direction that the sensory responses would normally be sent, this is called the orthodromic direction. If we were to do it the other way round, against the usual way in which a signal is transmitted, then that is the antidromic direction. This tends to be the modus operandi in the United States. This is what we tend to do in the United Kingdom. Now, when we send the signal, the first thing I want to show you over here is that you can see a big line at the very beginning. That is the stimulator artifact. That's the point of time that the stimulator is actually discharging. Then there's a period of time as the signal propagates along the nerve, and then as the signal goes underneath the recording pads, it generates this action potential. For the sensory nerves, it's called the sensory nerve action potential, or a SNAP. Now, there's a difference in how we actually pick up these different responses in terms of the sizes and the cleanliness of the signals, whether you do it orthodromic or antidromic. If you do it in the antidromic direction, then actually one ends up having, on the whole, rather large responses. However, because you're stimulating over here, you're actually not only stimulating the sensory fibers that will end up going to the finger, you're also stimulating some of the motor fibers too, and therefore one may have some muscle artifact contaminating the signal. Now, this is a relatively clean signal, but one can often have quite a bit of movement as a result, and that can actually make the response quite untidy, and that's one of the reasons that we don't really like doing that here in the UK. So this is what we tend to use here in the UK, the orthodromic stimulations. You can see here quite clearly it's much smaller than the antidromic stimulation, and the reason for this is actually remarkably simple. Over here, the recording pads are actually within millimeters of the underlying nerves, the digital nerves that run on either side. However, at the wrist, they're already buried under a fair bit of subcutaneous tissues and are therefore being insulated from being able to send the signal forth upwards to the recording pads. So the recording pads are somewhat insensitive to the currents going underneath them, and therefore there's this attenuating effect. And so that's why they're actually smaller. If we have a look at this example over here, this is actually from someone who's got carpal tunnel. The green response over here is the side in question, which happens to be the right side. And what we do over here is we mark up the sensory nerve response. So the first marker over here is the onset. That's the peak, and that's the end of it over there. And we actually physically measure the distance between the stimulation point and the recording point. We measure the time difference, and therefore we can work out the velocity in meters per second. In this example here, it's going at 42 meters per second between this point and that point there. And you can see, compared to the other side, it's shifted across a little bit in time. The signal's being delayed. And that's what happens in carpal tunnel syndrome. The earliest thing that happens is that the sensory responses start to become delayed. Let's have a look at the motor studies. So with the motor studies, we perform them in a slightly different way to the sensories. We don't have the luxury of sending signals up or down and recording directly over the nerve itself. Instead, we are actually stimulating over the nerve and recording over the muscle. And what that means is that not only are you recording the signal over the nerve itself, there's also neuromuscular junction and the time it takes for the muscle to depolarize too. So it's not quite as pure as with the sensory studies when one's trying to work out the velocities, particularly for the distal ones. So again, we're sending the signal. This is a stimulation artifact over there, and over here, this is the time it takes to reach the muscle and for the muscle to begin to depolarize. The green one over here is the muscle in question, and it's taken 5.4 milliseconds for the signal to reach the muscle and for it to become depolarized. You can see, if we were comparing it to the contralateral side, that this is occurring at a later time point than the left side would, and this is again what happens in carpal tunnel once it's already a little bit more moderate, and there's involvement of the motor fibers too. Let's now talk about the F waves. We all know that a nerve will enter a refractory period once it has been depolarized by voltage and time gating mechanisms, and that's to ensure that signal transmission is unidirectional. So usually we think we're going to be moving via our brain. That sends a signal down the spinal cord, and then at that point the signal will then start moving its way down into the foot. Now, these were first described in the foot, that's what they're called F waves, but if you were to stimulate someone's nerve down over here, for example the tibial nerve, not only will the fibers going distally to, for example, the abductor hallucis be stimulated, but some of the signal will be travelling up as well, and it will also be depolarizing some of the anterior horn cells, tickles them a little bit, sets them off, and then they in turn send a signal back down again. Roughly about 10% of the anterior horn cells will be stimulated by doing that, and one will therefore get an after contraction of about 10% of the entirety of the contraction. So when artificial stimulation occurs, the depolarization goes in both directions, and this particular property of the motor nerves allows that conduction to be assessed across the entire motor pathway to the anterior horn cell. So this is what it looks like in real life. The first thing that happens is, of course, one has the signal going to the distal point occurring. So one has the M wave, the muscle motor wave over there. And then sometime later, one has an F wave, which is, as I said, at about a tenth of the original M wave. And this is an upper limb study. It takes about 30 milliseconds, and that's a normal time for the signal to have gone all the way up, tickle the anterior horn cells, and then all the way back down again. We also have something called the H-REFLEX, and that's the electrical equivalent to the ankle jerk. Over here I'm doing it over the soleus, and what one's doing is one's stimulating at the popliteal fossa, and one is getting a signal out of the soleus, of course, but the initial stages of what will happen is one's actually sending signal, of course, in both directions, but over here one is actually going to stimulate the anterior horn cells at the S1 level, and they will actually start to send their contractive signals to the soleus. It will start to contract, and then what will happen is, as the impulses increase, and I'll show you this momentarily, there will be some degree of collision, and those will come off, and the motor responses will become more prominent. And it's quite a useful technique, particularly if one's looking at S1 roots or early Guillain-Barré, or just as a double check perhaps when the reflexes are clinically absent. One can often detect them electrically as a more subtle event. This is what I was talking about. So here's a stimulator artifact over there, and basically as one's increasing the current and therefore the stimulation, the first thing that happens is those anterior horn cells at S1 level are becoming stimulated. They are actually causing the soleus over here to be depolarized and to start contracting, and that's generating a signal over here. As one increases the amount of stimulation, that will increase in amplitude, and then at some point one starts getting collision of signals up and down, and the M wave, the motor response from the actual muscle itself directly, will increase in size quite dramatically in amplitude, and the H-REFLEX, the H responses will reduce in amplitude. So that's the H-REFLEX, and H for Hoffman, who first described it. In terms of EMG, it's very straightforward. We're popping in a concentric needle electrode into a variety of muscles. Over here this is an EDC. One can spend time and do quantitative studies as well, and actually isolate individual motor unit action potentials, or MUAPs, or MUPs as we tend to call them, and one can do cloud analysis too, looking at turns and amplitude. I'm not going to be dwelling on the quantitative techniques. So here's me having a bit of fun doing some motor evoked potentials. You can see me stimulating my motor cortex over here for the contralateral arm. You can see the recording electrodes over the APB, and here we go. You can see my hand contracting. I wouldn't recommend that you ever do these standing up, because it's so easy to get your legs to go if you can't aim it entirely precisely without seeing exactly what you're doing, as I discovered. So I wouldn't recommend getting your legs giving way from underneath you, but fortunately I don't have that blooper to share. And what happens over here is you can see these are the motor responses being recorded, and then basically what you will then do is mark up these responses, and then you can work out exactly the cortical latency, and you can also stimulate it over the brachial plexus, for example, or over the neck, and make a variety of calculations to work out what proximal conduction is looking like. Now we're going to go through a little bit of terminology here. In terms of our studies, our sensory nerve action potentials, we call those SNAPs, and for our compound motor action potentials, we call those CMAPs. So the axons give us the amplitude of any of these responses for sensorimotor. Our myelin is responsible for ensuring our conduction velocities. So for the sensory nerves, those are the sensory nerve conduction velocities, and for the motor nerves, they are the motor nerve conduction velocities. So in an axonal neuropathy, what one will be seeing is a reduction in the amplitude. One will have an essentially preserved velocity with that. Obviously there are always exceptions to things, particularly with vasculitis, but as axonal loss increases, one will have something called fast fibre dropout, and then the conduction velocities can fall too. In terms of the demyelinating neuropathies, we will expect to see a reduction in the conduction velocity with an initially preserved amplitude, and when amplitude does fall, and that's generally later, that's often due to failure of saltatory conductance. subsequently axonal loss. There are an important caveat I'd just like to mention now, particularly for some of the Guillain-Barrés, for AMAN, acute motor axonal neuropathy, or AMSAN, acute motor and sensory axonal neuropathy, versus early Guillain-Barré. Sometimes one can have very distal conduction block, and that can look like an AMAN or an AMSAN. And in terms of prognosis, one often has a poorer prognosis with those entities. And for some of those patients, it can actually just be a very early presentation of the Guillain-Barré. And so it's worthwhile making sure that one repeats the studies, usually about 2 weeks later, just to double check and being sure that it really was an AMAN or an AMSAN and it wasn't a Guillain-Barré, because then it can be far more positive for a patient's outcome. Let's talk a little bit more about demyelination. So of course we've got the focal demyelinating neuropathies, which you'll commonly come across and see and treat, which are the carpal tunnels and the cubital tunnels. Let's now get into diffuse demyelination patterns. So really important point to appreciate is the fact that nerve fibres aren't single cables. They are actually made up of numerous different fascicles with individual nerve fibrils inside, each having their own unique properties. Some will be larger, some will be smaller, some will have more myelin, some will have less myelin, and as such conduction velocities will vary. And so in the normal situation, you have a standard distribution effectively of some of those nerve fibres conducting a little bit faster if they're larger and more myelinated, so they'll be sending their signals the fastest, and some of them will be slower because they are smaller in diameter, less myelinated, and there'll be a whole cluster around about the middle. And this is essentially how you have these curves that we see with the sensory nerve action potentials, and similarly also with the motor action potentials too. When one has a demyelinating process, those demyelinating processes are often quite patchy. Some nerves are affected more than others, particularly more myelinated ones are going to take more of a hit, and so basically the clustering of the individual conduction velocities will start to splay out. That's temporal dispersion. And in this example over here, this is someone's tibialis anterior muscle. These are actually, apart from the fact that they are very small in amplitude, they're actually really, really broad. And usually this type of response would only really cover about 3 boxes at most. And here it's basically taking up 5. So it's definitely splayed outwards. The other phenomenon to talk about is something called conduction block. So as saltatory conductance fails, a variety of these fascicles are going to stop being able to send their signals altogether. So if we knock out half of these, for example, one will actually significantly reduce the motor amplitudes, and that's conduction block. So you can see over here in this example, this is someone's wrist, so conduction there is working okay, but over here in the elbow segment it's conduction block because one's actually got a significant reduction here in the ability for the nerves in the forearm to send the signal along. So that's where the demyelination is occurring, and it's quite significant. So in terms of patterns of demyelination, we are looking for slowing of conduction, which might be focal, particularly for the focal neuropathies. It might be multifocal, which might be different nerves and or even patches within the same nerve, or perhaps more generalized slowing of conduction, and of course conduction block itself and temporal dispersion. So how do we do our lesion localization? So we do multiple nerve testing, we test them in multiple locations, and then we have a look for pre and post ganglionic differentiation. So what I'm talking about pre and post ganglionic lesions is as follows. For the sensory studies, we are effectively testing the sensory fibers to their primary cell. So in the case of the sensory nerves, that's the dorsal root ganglion. So we can test the nerves up to the dorsal root ganglion. It does not cover the distance between the dorsal root ganglion and its way into the spinal cord before making its way up. So the primary cell body is well outside. So that's anything that happens to a sensory nerve must be occurring from its primary cell body outwards. However, with the motor fibres, its primary cell body is actually within the spinal cord itself, and so we can differentiate between pre and post ganglionic lesions when there is a discordance between sensory impairment and motor fibre impairment. So just look at this again in a little bit more detail. For a sensory fibre, you can stimulate anywhere along it, you can record anywhere along it as well, as long as you can get your recording pads or perhaps a recording electrode near enough to the nerve, and you can test it all the way up to its primary cell body, which is the dorsal root ganglia. When you're stimulating it, we start at time 0, we then have the time it takes to arrive at the recording point, and then one has the response over the recording area. And so what we measure is the latency. Over here we speed is distance divided by time. So whatever that distance is between the stimulating point and the recording point, we divide it by the time, and we get our meters per second for the conduction velocity over here. We determine our amplitude between the baseline and peak. There are different ways of determining what you're measuring, but over here this will be the sensory nerve action potential in how I'm choosing to show that to you at this moment in time. In terms of the motor fibres, again, just to show you schematically, the anterior horn cell is a primary cell body. With electricians, we can test along the circuit all the way to the primary cell body. That's living within the spinal cord itself. So a preganglionic process, that's a process occurring before the dorsal root ganglion, will be affecting the motor fibres, but it will not be affecting the sensory responses. So a sensory response will be unaffected by a preganglionic process. However, a postganglionic process, a peripheral neuropathy, the sensory responses will be reduced by it. Again, for the motor studies, we stimulate over the nerve itself, the signal goes along, hits the neuromuscular junction, signal transmission has to occur, and then we'll record over the muscle membrane itself. Again, we have the time it takes from stimulation to the point that the muscle starts to contract. Now, we're very exact people in neurophysiology, and the time it takes between the point of stimulation distally to the point that the motor responses are being recordable is a very short time period. It's just a couple of milliseconds. Neuromuscular junction transmission is about 1 millisecond, so there could be a fair bit of error in trying to work out and also guesswork for an individual to work out what the exact conduction velocity might be at the distal point. So what we do is we literally just record the distal motor latency rather than trying to calculate a distal conduction velocity. As we move more proximally and we stimulate more proximally, so we then get a more of an intermediate latency, and then we just simply have to work out the difference in the distance between the distal and the more proximal stimulation, and do a similar calculation with the time difference as well, and then we can actually work out a exact conduction velocity for all the more proximal segments as we work backwards. So for the most distal part of conduction, we rely on the distal motor latency. For more proximal stimulation, we can actually get conduction velocities, motor nerve conduction velocities calculated from any of those individual points. The F wave, just to show you again, as we stimulate at any point over here, the depolarization will spread in both directions. The first thing will happen is you're getting the M response directly from the muscle itself. At some later point, one's getting the comeback tickle, as it were, from the anterior horn cells, which then go and stimulate the muscle fibers again, and that's about 10% of the response. For the evoked potentials, we can either have a look at the central pathways, the central somatosensory pathways via SSEPs, that's the somatosensory evoked potentials, or we can look at the motor pathways with the CMCTs, so that's when you stimulate magnetically over the cortex, stimulates the central pathways to the anterior horn cell, and then one can basically subtract off via the F response what the central pathway conduction is like. With the central somatosensory pathways, one can actually track the signal going up. We're putting electrodes at a variety of different places, and you can actually have a look quite directly at the central somatosensory conduction times. Let's move on to EMG. I've got separate videos on EMG itself. Basically, we use a concentric needle, a needle within a needle, to record the potential differences. We record the muscle motor unit action potentials, the MUAPs, or just call them MUPs, it's a bit easier to say. We can see exactly how the muscle is controlled, that's the recruitment. We can see how much muscle fibre is being sort of brought in, so therefore how much muscle fibres are present, and that's the interference pattern, that's the degree of how much muscle contraction and therefore electrical representation is making the screen busy. And we can have a look at the electrical characteristics of the muscle and therefore determine whether there might be a myopathy or a nerve lesion. And we can have a look at the degree of axonal continuity if there are nerve lesions. And we can also have a look for signs of recovery, videos and all of that separately. The very fundamental for a myopathy is if this is the recording field that is open to a concentric needle electrode, there are a variety of different muscle fibres within that. As a muscle becomes sick with a myopathy, they will shrink down these individual muscle fibres, and therefore one have a small amplitude response out of them. Because you've got lots of them now clustering around the actual needle itself, they will become polyphasic. Also, because they're not able to generate force very well because they're small and they're very sick, the brain will be recruiting more of those to join in and generate force, and therefore they'll be rapidly recruiting, and so one ends up having a full interference pattern with submaximal effort. And let me just show you over here. So these muscle fibres are recruiting very, very rapidly, and over here it's not as orderly as it should be, and these are small polyphasic units. Let's now move on to the basics of EMG. Again, this is a complex topic and there are lots of different parts to this, but in terms of the basics, let's just work through a chronic state. So if this is the recording field over here, and now I've highlighted muscle fibrils which have been innervated by different motor units. So if we have a neuropathic process that's occurred, we've wiped out a whole bunch of different muscle fibrils over here, and terminal sprouting has occurred, and then some of the motor fibrils will now be converted, as it were, and are now sort of sucked into the remaining motor unit. So for example, if we take this motor fibril over here, it's now part of this motor unit, or for example this one over here is now converted into part of this motor unit, and so therefore there are more motor fibrils contributing to the motor unit, so it becomes larger in amplitude. They become quite wide as well because they're now more dispersed and therefore further away from the needle electrode. The recruitment will be abnormal because one's lost out the orderly accumulation of fibres of increasingly larger size, the Henneman principle, and of course the interference pattern will be reduced because there are fewer motor fibres to be recruited in. So this is what they look like: large polyphasic units, and they basically sound like popcorn. It's a very simple way of looking at them. In terms of the spontaneous activities which we may see with EMG, you may have heard of increased insertional activity, and that's when you stick the pin in. There's some muscle membrane instability, someone's getting some discharges which are non-sustaining, occurring for a brief period of time. Those can be the earliest signs of some active process occurring. There may be positive sharp waves or fibrillations or complex repetitive discharges. I have separate videos on those. You can have a look at those in your own time. And there may be things such as myotonia. That's purely generated from the muscle themselves. In terms of nerve, spontaneous activities, fasciculations and myokymia are nerve origin spontaneous activities, and fasciculations are super important, particularly for differentiating between entities such as motor neuron disease and inclusion body myositis. That's a super important clue, particularly in the earlier stages. So in terms of pre and post ganglionic differentiation, so for a post ganglionic process for peripheral neuropathy, you're looking for reduced or absent sensory responses. If the motor fibers are involved as well, they may be reduced or absent. And again, similarly, in terms of the EMG, if motor fibers are involved, then the EMG may be abnormal. In terms of preganglionic, which is either at root level or anterior horn cell, one will be expecting to have normal sensory responses because their primary cell body is away from where the pathology is. The motor responses may reduce or absent, and you would be expecting abnormal EMG. So in terms of what we're looking for, we are trying to see the type of problem affecting the nerves. Is it axonal? Is it demyelinating? Is it something which is mixed? Is it something which is affecting a single nerve, multiple nerves, all the nerves? And then we know which nerve fibers are being affected, sensory, motor, possibly autonomic, or all the above. And so we're looking for an overall pattern as to what's going on. Are we looking at just focal compression sites, entrapment neuropathies? Are we looking at distal neuropathies, length-dependent neuropathies, generalized neuropathies, multifocal neuropathies, proximal neuropathies? Whole variety over there, and they can all give you a clue as to what's going on. Now, one of the misnomers which I think is important to correct and to point out is that neurophysiology is clinical neurophysiology. It's a clinical specialty. It's all about the history. It's not just about the electrics. So one has to look for the clinical clues, looking for congenital issues, whether they're acquired issues, maybe trauma, which is often very obvious, inflammatory, infective, neoplastic, metabolic, vascular, degenerative. You have to be able to integrate all of those together. So it's not just about the actual data itself. It all has to be put together and packaged up. Thank you for watching. I hope you found this video useful. I really do value your support. Please do support the channel by liking, sharing, and above all subscribing. Many thanks, and I'll see you in the next part shortly.